Hello, everyone. Thanks for taking the time to listen to me talk about benign prostate disease, which is known in the world of urology as BPH. I'm sure a lot of you have heard of that term before, which stands for benign prostatic hyperplasia, which stands for enlargement. So we're not talking about cancer. We're mainly talking about, how the prostate enlarges and what are some of the symptoms and what are the options we have. Our focus today will be at the end is typically on how to treat this disease using minimally invasive therapy rather than having to go through what we call the rooter in the layman term, or the TURP or laser procedures for the prostate. So without any further delay, we're going to proceed. I'll make this as short and concise, so I hope we get you to your regular activities after this. So where do we go from here? Just forward.
John will be moving your slides for you.
Oh, okay. Someone do, okay.
Yeah.
All right, next slide, please. So the prostate is a gland. People always say, what does a prostate do? It's mainly for fertility. So, after you're done having kids, it has no essential function, for the human being or the male. That's why when you remove the prostate for prostate cancer, it's not an issue. It's like an appendix per se, or a gallbladder. So the prostate's just an organ that sits, between the bladder and the urethra. That's the tube that we urinate from. And that's the tube, the channel that comes from the bladder, goes to the prostate itself and all the way out to the tip of the penis itself. And it produces fluid that transports sperm during ejaculation. So that's why it's mainly for fertility. The prostate conditions are, that can develop as we mature, or instead of aging, that's the term I like to use with my patients. It's enlargement, benign enlargement. We also have patients that can suffer from what we call prostatitis. And we also have the thing that we can get concerned about, which is a common condition. Men, probably 1 in 5 men that present to our office has prostate cancer. And that's something we're not discussing today. We'll be doing another talk, hopefully sometime in September, that's prostate cancer. And we'll talk about prostate cancer and diagnosis and treatments. So age condition obviously affect, the prostate differently and are treated differently. So enlarged prostate affects more than, I would say even more than that, probably 30, according to the studies, 38 million men in each year in the United States. And then people say, well, if you live to be 100, you're going to have a problem with your prostate. And that's true. As if you look at people that are 90 years of age, probably 90% of them will have some prostate issues. 80, I would say 80%. So that's always the percentage that I use based on patient's age. So if you look at the thing, so people that, at the age of 80, 90% will have some issue with prostate enlargement. For nearly half the men in the United States with BPH, their symptoms are severe enough that it affects their daily activities. And usually that's when they come in and seek, treatments. How can we go about taking care of these symptoms and get my, life back in order? Next slide. As I said initially, BPH is a term that we termed the benign prostatic hyperplasia. So it's not cancer. It's just a benign enlargement. And people say, well, me having a big prostate, does that mean I'm higher risk for prostate cancer? No, absolutely not. It just, we have people with a small prostate that have prostate cancers. And so size doesn't correlate with risk for prostate cancer. And at times, sometimes even size doesn't correlate with symptoms. Those guys that have bigger prostate doesn't mean that they have, more symptom than guys that have smaller prostates. But what happened is typically, if you look at the pictures, is as a tube that empties the bladder, goes right through the prostate. The channel become compromised as the prostate enlarges. It starts pushing on the channel, and you can see the channel narrows, and that's what happened. That's when the symptom develops. So we don't see 20-year-olds and 30-year-olds present to our office complaining of prostate enlargement symptoms. We see it more commonly, about age of 50 and on, particularly in the 70s and 80s. That's because the prostate, as we grow, gets bigger and bigger, and then start pushing on the tube called the urethra and causes some obstruction, leading to different, symptoms. And this is a little closer diagram telling you the anatomy. So you can see the bladder, and you have the prostate, and this channel called the urethra. That's called the prostatic urethra. And as the channel as the prostate enlarges and becomes what's called hypertrophied, it becomes enlarged. It causes this obstruction of the flow. So now what happened is the bladder has to push harder to go through this narrow channel as compared to having this wide, nice channel. The bladder starts pushing harder and harder to go through this narrow channel. And what happened then is like your bladder becomes like a weightlifter. So it started developing these muscles called hypertrophied detrusor muscles, and become thicker and less compliant. And a guy who wants to work out and looks good, that's great. But if someone for the bladder, that's not very good. That's actually one of those things that can lead to bladder dysfunction eventually. What happened is that the bladder becomes unable to store the urine very well, be very difficult to empty, and at times the bladder gets to a point where we call it a fried bladder, quote unquote. It just doesn't work no matter what it is. Next slide. So this is the progression, and you can see the pictures that we've taken in the operating room at times, and you can see that the initial picture on the left-hand side, you have a nice open channel. The dark area there, that's actually the bladder. That's the scope just before we get into that. So this is the prostate, looking from the prostate into the bladder. And if you look into it, we start looking into the enlarged prostate, you can see how that channel starts getting closer and closer. And eventually, the prostate is so enlarged, it restricts the flow of the urine. And you can see when you're looking in there, we call that a visually occlusive prostate. So when I scope my patient in the office, I see that two lobes are what we call the kissing lobes or touching lobes on the right picture on the bottom. And that tells me that this patient is having a hard time emptying the bladder because the tissue is not separating. They're kissing them, touching each other. So that's how the progression, is noted on a cystoscopic examination that we see during clinical practice. Next picture. So how do we know a patient has some issues with urination? Well, typically they complain mainly of frequency, having to go to the bathroom quite a bit during the daytime, having to go urgently when they gotta go, better find the bathroom. They have very difficulty postponing urination, and at times they start leaking urine. They can't hold it. By the time they get to the bathroom, they already have some incontinence, so leakage of urine. They also complain having to get up, a few times at nighttime. That's called nocturia. And patients say, well, you know what, I can get up once, twice, but if I get up 4 or 5 times, they complain of, they can't get enough sleep and they're tired all day long. And that's where they come in. Then the other issue they have also, they say stream is so slow, it takes me forever to empty. I'm having a hard time starting. It takes a while to get going, then it slows down and back up again. So that's a classic, symptom for benign prostatic hyperplasia. And thusly, like we just mentioned, it affects the quality of life. And, patients start, avoiding travel. They can't do any leisure activities like going to a movie theater. They're having, using the bathroom stall instead of the urinals because they have to sit down and push to get the urine out. They can't do it standing up. And most importantly is, disruption of sleep patterns. Next. For me, as I mentioned, most guys, when I see in my office, that it's got to the point where it becomes pretty extreme because a lot of them, they say I can deal with it, here and there. But when it gets to the point where the patients, are affecting their daily activities, that's when they start coming in saying, hey, I need to see a urologist, or try these medications, nothing is working for me. And that's when we start seeing our patients. When they come into our door, the office, first thing we do obviously is a medical history. And then we start talking about physical examinations. And most importantly for me, when a patient comes in complaining of prostate symptoms, is getting a PSA, making sure the PSA within normal limits. We also do a scan of the bladder, make sure that they're emptying okay, they're not a retention, and examine the prostate. We also do something called the AUH symptom score. That gives me an idea, objective measurement, and how much this is bothersome. And ranges anywhere from 1 to 35, and anything from, let's say, up to 10 is like mild. Anywhere between 10 to 20 is considered moderate, and anything more than 20 is considered severe symptoms. So it gives us an idea how bad those symptoms. We use those with symptom score as a way of measuring how treatment is effective or not. We do one before and we do one after, and we see how the symptom score improve after the treatment. Go ahead. Other studies I sometimes do now, a lot of the insurance companies have become more and more picky on what can we, and when we try to do pre-authorization and approval for a procedure for the patient. And now they're requesting at times obtaining a uroflow, pressure flow studies. And these are where the patient comes in, have a full bladder. We have him void in a special device and give us a graph. So an objective measure. And typically in a young guy would see the flow goes very quickly and empties very quickly. And as someone who has some issues, it becomes like we call a flatliner, like a flat line that takes forever to empty with zigzagging. So tell me the patient is obstructed. So it's an objective measure. They also are now requesting at some time is measuring the prostate size, because certain procedures, the minimally invasive therapies, you have to have a certain parameters of certain sizes. The procedures can be, let's say, between, 30 and 100 gram prostates. If it's smaller than that or bigger than that, then they might not approve the procedure. And also, lastly, we also do a cystoscopy, which I think I always do them on my patients to rule out any other potential of any other causes, like a stricture or any diseases, like cancer or something in the bladder that could be given the same symptoms, but also give me an idea if this patient is a good candidate for some of those minimally invasive therapies. So that's why I do the cystoscopy or looking into the bladder. Next. So this is the AUA, we call the AUA symptom score I was telling you about. So patient comes in and they start rating their symptoms, from 0 to 5. And the things that we ask are, 7 things: incomplete bladder emptying, frequency, intermittency, urgency, weak stream, straining, and nocturia. That's how often you get at nighttime. And then we get a score at the end, and then gives an idea where the patient is, and, from between mild, moderate, or severe. Next. So people say, well, what if I leave it alone? Am I okay? Do I have to have something done? And I always answer my patients, well, it depends. I mean, if your bladder not emptying very well, that's not good, because if you have a retention and you're backing up the urine in your bladder and eventually into your kidneys, then you can end up with kidney failure. So a lot of guys that have retention, we have to put a catheter in them to drain the bladder, because otherwise they end up with kidney failure. Sometimes you can form what we call bladder stones, because the urine is retained and into the bladder. So we have to go in and open, take the stones out, because there can be source of infection. But eventually what happens is, if you don't do anything about it, the bladder becomes so, so thickened and less compliant, it may stop working eventually. So really want to try and reverse the process by relieving the obstruction, by doing some form of therapy to hopefully, get the bladder to start emptying a lot easier and not be as thick as we mentioned earlier in the program. So what are your options for enlarged prostate? Well, watchful waiting is an option, but we have to keep a close eye on it, make sure it doesn't progress anymore and leading to we call a crippled bladder. So you have to keep an eye on it. If patients start developing difficulties, higher residuals in the urine, or recurrent infections of bladder stones, then it's time for treatment. And also depends on the patient quality of life as well, and subjective feelings about how they're doing on daily basis. The other option is phytotherapy. I use it. It's called like saw palmetto and lycopene. These are the things that you can, like sunflower seed extract. You can hear, you've seen the commercials on them, correct? And all these football players, they use them and how great they feel. It works. I think in mild cases, and I think it works in the moderate to severe cases. And for those cases, I really move right on to the medications. And if medications doesn't work, then, we can go on to different options called the radiofrequency ablation. We have the urolift, that's something we're going to talk about later on. We have the Resume, which is a vapor therapy, same thing. It's going to heat like the radiofrequency or microwave. And then you have the surgery, like we talked about, the TURP, the transurethral resection of the prostate, or the laser, which is photovaporization of the prostate. So these are all different treatments and different options, and it's all available options. Next. So watchful waiting. Advantages, obviously no surgery, cheaper than drugs, no side effects. Disadvantages, may not have the symptom improvement. And if symptoms, rest of the symptom will worsen, which I think they all typically eventually do end up worsening with time. So it's not treatment, it's just watchful waiting. As I talked about, the herbal medicine, same thing. It's not a drug, not surgery, no side effects typically. But in my opinion, for the moderate to moderate cases, I don't think it works. So the symptoms potentially may worsen, and potential downstream issues would be bladder stones, like we talked about, bladder health, and kidney function. Next. So medications. I think everybody have heard of the term, Flomax or Avodart or Proscar or Jalin. Now even we're using daily Cialis to help with the prostate. And those medications do work in some situations. So they don't require any surgery. They may provide enough for symptom relief. So out of all my patients, I always try my medications because I think I can document, hey, I tried medications, nothing happened. We need to move on to the next step. But everybody in my clinic have to be on medication to see if that works. Now, some of my patients that come in, they've already been tried on medication by their primary care physician. So they've already come in, I've tried this, and nothing worked. So they've already been through the medication cycle. I have some patients that said medication is too expensive, or medications causing side effects where I really want to be off medications. Do I need to be on this medication the rest of my life? So I always say, you do, so a lot of guys don't want, say, well, I'd like to discuss other options besides medications. So just because it doesn't work, that doesn't mean, just because it works doesn't mean you don't have any option of doing anything else beside, the medication, because some people don't want to be on medication, or if they have side effects, then they can like to go on for the next step. Next procedure. Thanks. So what are the treatment options? So we have something called the prostate heating, and that's the microwave, the transurethral needle ablation. Now it's called radiofrequency ablation. I've done a few of those. I don't do the microwave. One of my partners did. I wasn't too excited about it. I've done some radiofrequency in the past with good results. The advantage is an in-office procedure. We do it under sedation and some local anesthetic. Insurances covers it usually, and fewer side effects, than surgery. Disadvantage is you may have to have the catheter in for a few days, because when we do these treatments, the prostate does swell up, initially. So the symptoms, what happened, it doesn't get relief right away. So you may have to, watch the symptom for a month or two. So I tell my patients, you see improvement in 1 month, you see improvement in 2 months. By 3 to 4 months, my opinion, that's going to be it. That's going to be the maximum therapy in 3 to 4 months. After that, I think that's the best you're going to get from these procedures. So initially, you may have to deal with some issues with urination, have to have a catheter in, but that's a disadvantage of this procedure. Surgery, you've heard of the term, the router, the TURP. It's a gold standard, and it's still being utilized, and I do a lot of it. For those patients that have, really enlarged prostates, or they have tried different medication, tried different therapies, or I feel that when I do the cystoscope or the examination, in the office, we look in the camera, that these patients are not a candidate for any of those minimally invasive therapy, then I go to the TOR. I don't use a green light much. I use it every now and then, but I lean more towards the TOR. I think it does a much better job. And the advantage that, if you can see with the picture, is you put a scope when you're asleep in the operating room, and then through that, what we call the resectoscope, we use electrical energies to resect the tissue. So you almost like dredging a channel. You take the tissue and you open the prostate up, and you can see how we create a little bit of a like a channel. And what happened then, the patient will see immediate improvement in their flow. That's like I feel like a horse. Oh my God, I can't believe it. I'm like a 10-year-old kid again. Some people have to back up from the toilet because what happened, they used to stand so close, otherwise they dribble on the floor. So now they have to back up because the stream is so strong. So it works, and it works very, very well. But, when you have something that's more of a surgical procedure with more associated risks are implied as well. Potential for what we call bladder neck contraction of scar tissue, strictures, that's 7%. Potential for leakage of urine, about 3%. 10% would have some erectile problems. You cannot do any heavy lifting. And for me, about 2 or 3 weeks, not 6 weeks, just take it easy. Catheter is about 2 days for me. Put the patient in catheter for 2 days and we take it around the office. Patients are on blood thinners. That's one thing I was kind of worried about because within 7-10 days, the potential for rebleed if you go back on your blood thinners as well. The one thing a lot of patients don't like is what's called the retrograde ejaculation. That's the loss of ejaculation. You'll have a normal orgasm, but what happened is you will have a loss of ejaculation. Nothing will come out. It's no big deal. I always tell my patients, unless you're trying to have a baby, but most guys at that time, they're done with that. Or if you're a porno star, then that's a problem. But otherwise, no worries. So it's one of those things but I always inform my patients because some patients really become very bothered with it. And I think, I tell my residents that, make sure the patient are aware of that issue because that could be something that they may not be happy with. So there's a very strong potential loss of ejaculation. Next. So what I've been doing, before UroLift, I did the Prostiva. We had some good results, but since the UroLift, we are now the Center of Excellence in mid-Michigan. I think there's only 1 or 2 centers in the entire state of Michigan. What that means is that we have excellent results. The company knows that we have excellent results. We do a good volume of this procedure with very good results. And that's why we get termed the Center of Excellence. There's a lot of guys that are doing it, but they're not Center of Excellence like we are. So I am the guy in mid-Michigan that does this quite a bit but I'm also selective who I do it on. That's why we have good results. So the advantage, again, it's an in-office procedure. It takes me about 5-10 minutes to do. I do it typically every 3-4 weeks. We do like 6-7 minute time. It takes me 5-10 minutes. Patients have no issue with ejaculatory dysfunction, no ejaculatory issues, no sexual dysfunction. Patients usually, I would say maybe 10%, 20% would have a catheter in place for a day. Majority don't have to have a catheter in place. And so far has been really durable for about 5-6 years. Now, some patients will come back a year or two, let's say it's not working. Some guys say it worked great. I think the success rate, in my opinion, about 80+%. So 20% will see no improvement. Now, does that mean the end of the line? No, absolutely not. We do the UroLift if that doesn't work, and there's 10, 20%. We can go on to the TURP if we have to. The disadvantage, some discomfort, some bleeding in some patients. It's covered by most insurance, if not all. So overall, it's really, it's a great procedure. So I've been really leaning on this procedure and haven't been doing much of the radiofrequency or the heat therapy. That's my first line of therapy for minimally invasive procedures. Next. And this is an FDA, been since 2013. I think about 250,000 men have been treated with this procedure. And it's typically, it's patients, can come into the office. We discuss all the, other, medications, side effects. We probably do the uroflow, the flow studies, the cystoscope, maybe do an ultrasound volume to make sure that you're a good candidate for this procedure. Next. So the benefits comparison between all the ones we just talked about, and you can see the UroLift on the left-hand side, then you have the TURP, the photovaporization, the transurethral microtherapy, and the medications. And you can see really, it's the UroLift hits the marks in all of them. Minimally invasive, rapid relief, great results, no cutting, no complications typically, no bleeding, none of the stuff, preserved for sexual function, and no issue with incontinence. Never had one single case of any leakage of urine. Can be performed